Thanks to Dr. A. I have the honor of introducing our speaker this morning. Dr. Carrion, if he can forgive my pronunciation, is joining us today to give us a talk about endoscopic management of biliary complications after liver transplant. Dr. Carrion grew up in Ecuador, did his schooling there, and once obtaining his MD, came to Miami at Jackson Memorial Hospital, and they must have liked him there because he spent a few years there, completed his internal medicine residency as well as a GI and a transplant hepatology fellowship there. After completing his training, he joined the staff in El Paso at Texas Tech and serves there as the director of hepatology, the medical director for GI endoscopy, and also serves as the associate program director for their GI fellowship program. He splits his time, I believe, between treating patients with liver disease as well as performing diagnostic and advanced therapeutic GI endoscopy. Has over 40 publications in peer-reviewed journals and renowned textbooks, and has presented his work at some of the big meetings consistently, including AASLD, DDW, EASL, and ACG. Has contributed to the upcoming editions of Schlesinger and Fortran's GI and liver disease texts, as well as Schiff's disease of the liver, and has received numerous honors, including AOA and the Bacchus Alumni International Society for GI. So without further ado, I'll let you talk to us about your topic.
Thank you so much, Dr. J. Thank you for that kind introduction, Dr. J. Is this working? Not really. No. Okay. Well, thank you so much. Again, thank you for a kind invitation. It's really an honor and a true delight to be here again. I was here in 2015, I believe, right after I moved to El Paso, and this time I decided to bring a topic that's near and dear to my heart, and this is what really got me very interested in a combination of sort of endoscopy and liver disease, which is, at least in my mind, was relatively odd back then, and people couldn't understand why I was trying to do both things. But now I'm a bit more reassured, especially since during this liver meeting in DC just this past month, I saw a couple of people that have done exactly the same thing, so I don't feel like a strange type of animal now. But the endoscopic management of biliary complications in liver transplantation, it was really something that caught my attention during internal medicine and GI training at the University of Miami. We had a large abdominal transplant program, and they continue to grow, as I've seen recently. The management of complications was really something that fascinated me. So I'm going to be talking a little bit about this, and I thought it would be important for you, obviously, because you're going to be dealing with this over and over again. So the objectives of this talk for today are to review sort of the commonest complications that occur in liver transplant recipients and try to provide a sort of an algorithmic approach for diagnosis and management. And obviously the management is going to be relatively biased towards endoscopic therapy, as this is what, again, I've been sort of focusing since training. So just to begin with some generalities about biliary complications in liver transplant recipients, these are a very important cause of morbidity and mortality, and as you know, they can occur in a sort of a wide range of patients, going from 5 to almost 45% of liver transplant recipients. And obviously you have a living donor program, so you're going to be seeing a lot more in that population compared to your disease donor transplant population. Now, when we talk about the types of complications, you're well versed on this, but just to remind you, what we'll be going to talk today is bile leaks and bilomas, which are sort of the commonest out of all, particularly in disease donor. You can get up to 25%. Stone, sludge, and cast, which account from somewhere 5 to 18%. Strictures, which are, again, something that we see relatively common in disease donor and obviously much more common in live donor liver transplant. Sphincter of Oddi dysfunction is something that we don't see that often, and again, this is similar to the non-transplant population. It has its own issues with diagnosis particularly. And then there are other issues like hemobilia, mucoceles, bacteremia that we're not going to be spending too much time on. So What's important is to recognize the timing of biliary complications, and this paper from almost for now 16, 17 years ago made this nice plot in which you can easily notice that leaks and anastomotic strictures occur very early on post-transplantation. The rest of the complications tend to be more the sequela of the early complications, and that's what you're seeing several months down the road. And it's usually the more ischemic type of events, like ischemic strictures that will lead to stone sludge and cast. And then you also have these issues with ampullary stenosis, mucocele. That could be a result of early interventions with endoscopy as well. Now, why do we care about biliary complications liver transplant recipients? Obviously, because they have an adverse effect on patient and graft survival. So this paper was a retrospective study and nicely plotted out people without biliary complications, liver transplant recipients without biliary complications, did much better than patients with biliary complications. So again, it's affecting patient and graft survival, and it's something that needs to be identified early and hopefully treated also quickly. The risk factors for these problems are various, and you can group them in different areas. So if you talk about the recipient related factors, age of the recipient, the MELD score, and ABO mismatch play some role. Specific to the disease itself, PSC and extrahepatic cholangiocarcinoma can have an important role because of biliary reconstruction and sort of dissection of the bile ducts. When we talk about the surgical or technical factors involved, if there's extensive dissection during procurement or excessive use of electrocautery, this has been put as a risk factor. If there's tension to the bile duct anastomosis, that's not going to help, particularly with blood flow to that specific area. And the use of T-tube has really fallen out of favor. At least that's what we saw in Miami, particularly after we had sort of a change in the surgical team. Pretty much T-tubes disappear from practice. And this is sort of the case across the country. T-tubes are used very rarely for particular cases. Now, the type of biliary anastomosis has an important role in the management of this type of complications because if it's a Roux-en-Y bilioenteric anastomosis, we're going to have a very difficult time trying to get to that anastomosis to begin with. Not to say that we can now in a decent proportion with balloon-assisted techniques, but it creates a real challenge, and we usually have to book ourselves for at least half of the day free to be dealing with this. Allograft-related factors that can lead to complications include donation after cardiac death, older age of the donor, ischemia times, and obviously the size of the duct. If there's a mismatch, that's going to put a liver strain in the blood flow to the bile ducts. And the use of preservation solutions, HTK versus UW, has been brought up as maybe one has a slightly better profile with regard to biliary complications, and this is again favoring HTK. Post-surgical factors, hepatic artery thrombosis, stenosis, or infections, those can be major variables playing into the development of this type of complications down the road. Obviously, again, you do the living donation, and this is something that's associated with a much higher risk of biliary complications, both in the recipient and obviously in the donor that otherwise would not have any biliary complications induced by the surgical intervention. But in recipients, it's been compared to disease donation, and we have about a threefold increase in biliary complications in the recipient. And the donor can get somewhere around 9 or 13% per previous reports. Now, what's worth noting is that these reports are not sort of in the past couple of years, so you can argue that surgical techniques and procurement from the living donor have changed a little bit, and maybe now we're facing a slightly lower frequency. Now, strictures itself are a big problem, and in living donation, you're going to be facing this up to 40% of the time, compared to 4 to 13% in the deceased donor. And the diagnostic approach should be sort of a well-established approach, and usually each center has its own little nuances in how they deal with patients. But the clinical symptoms are not very helpful. Patients are usually 100% asymptomatic unless this is a high-grade stricture or a bile leak that's causing significant biloma with abdominal pain. But majority of patients present asymptomatic. Elevation of the liver chemistries is something that's usually picked up right away by transplant teams, because that's what we're looking at all the time. After transplant, only things we care is how the chemistries and the patient is doing. Imaging studies are usually followed for elevation of liver chemistries. Transabdominal ultrasound with Doppler is sort of routine in the post-transplant setting, as you're well familiar with. But the sensitivity for detection of biliary complications is not great. For biliary obstruction particularly, the sensitivity can range from 38 to 66% or so. It's quite specific. So actually, when you notice a severe dilation of the bile ducts, you can have around 90% specificity or so. But as you see, the sensitivity is what's really lacking, and that's why usually it's used for evaluation of flow and resistive indices, but not so much for the biliary tree itself. What really has a good diagnostic characteristics is MRI and MRCP. And you can see there that well above 90%, you can diagnose biliary complications with this technique. A HIDA scan, again, sort of relatively low sensitivity. You'll probably get the same with a flip of a coin, but it actually is quite specific, particularly for bile leaks. It has a role. EUS is something that's coming up more and more, and when we were in Miami, we got started with using EUS, particularly for anastomotic strictures, and actually it's more of an academic sort of exercise, because it lets you see the stricture very nicely from inside with a high resolution quality, but I don't know if it really adds anything really valuable to the procedure itself. So we were doing a sort of EUS, ERCP, just to sort of grow ourselves a little bit in the diagnosis and sort of the imaging characteristics of the strictures. For ischemic strictures, doesn't really help you that much, because you cannot access that part high up in the liver. With EUS, you lose a lot of spatial resolution up there. Now, for diagnosis and therapy, you have ERCP and PTC, which are really the standard of care. And ERCP has gained quite a bit of ground over the past several years, 1 or 2 decades, I will say. So this algorithm was put up by a group in Barcelona, and it actually makes quite a bit of sense. And it goes again with the fact that you're not going to be asking the patient for symptoms, but you're more focused on the liver chemistries and abnormalities there. If there's an abnormal liver chemical profile, that's probably going to be followed up right away with an ultrasound with Doppler to evaluate the hepatic artery flow. And if we see any dilatation of the bile ducts, that's going to be sort of an indication to proceed with therapy or a therapeutic intervention, which ERCP is the preferred one. If there's ascites or viloma, then we'll be talking more about a percutaneous drainage of that area, and then considering if there is or there is not a communication with the bile ducts, and that usually can be done non-invasive with MRCP, and if there is one, ERCP will be indicated. If the ultrasound is completely normal, then your clinical suspicion starts playing a major role, and a liver biopsy may be on the table to rule out rejection. As you know, this can be easily confused with episodes of rejection, and most of the times the patients end up getting sort of an imaging study and a liver biopsy almost right after, if the imaging didn't help that much. So let's focus a little bit about biliary strictures, and now we'll go sort of problem by problem. For biliary strictures, obviously we have 2 types. One can happen right at the anastomotic site, and the other one that can be non-anastomotic or slightly higher up in the intrahepatic segments of the bile ducts. The anastomotic type of strictures are the commonest, with 80% of strictures being located at this area, and they're usually related to some technical issue or ischemia right at the anastomosis. So blood flow has been relatively compromised in that area, and we're seeing some fibrosis develop in the upcoming weeks after transplant. It's usually a single, very focal stricture, again, right at the level of the anastomosis, and tends to be quite short in length. This contrasts completely with non-anastomotic strictures, which are, again, higher than the anastomosis, usually 5 millimeters or more, and they tend to be long, extensive, usually multiple, and ischemic in nature. So very different imaging characteristics. And the timing is also important for anastomotic strictures, because if it's an early anastomotic stricture, usually you can relate to some technical issue that happened during the procedure itself. If it's a late stricture that presents after a month, then you're talking more about a vascular type or ischemic type of issue that's leading to fibrosis. So again, the majority of anastomotic strictures are going to be diagnosed within the first year. If you have to put your money in, probably within the first couple of months. And MRI or ERCP are going to pick them up readily. MRCP, again, being non-invasively, is a nice way to start the workup. In Miami, the surgeons didn't really want to wait too much for MRCP. Usually they wait for an MRCP somewhere between 12 to 24 hours. So ERCP can actually have a diagnostic role, but it has to be weighted with the clinical suspicion. If the clinical suspicion is low to intermediate, you should probably wait a couple of extra hours and get the non-invasive test. If the clinical suspicion, on the other hand, is high, you may proceed straight to ERCP and start getting sort of a diagnostic and therapeutic procedure all in one. The endoscopic management, the success of endoscopic management can vary from about 65 to 100%, and this is related to multiple factors, related to sort of the stricture itself. It can be related to endoscopy's expertise. It can be related to the type of anastomosis that was created and things like that. So obviously you see there the predictors of failure. A Roux-en-Y biliary anastomosis is going to create a major challenge for the endoscopist, and again, a balloon-assisted sort of technique with an endoscope is going to be used in order to try to reach that anastomosis. Previous bile leaks, history of previous bile leaks is going to create an issue because of fibrosis. Usually this tends to imply a more chronic process going on than a fresh stricture that's just been identified 4 or 5 weeks after transplant. And living donor liver transplant recipients pose also an important challenge because of the differences in the biliary anatomy compared to a diseased donor. So what's important is that we need to identify these problems early on, because early treatment translates into faster resolution. So this data from the Mayo Clinic in Scottsdale showed that the earlier you identify the problem, and this is highlighted by this dotted line here, the less number of procedures you're going to be needing compared to later diagnosis. You're going to be requiring many more interventional procedures in order to get a response. These are some pictures of what we did before in the endoscopic management. So when we're talking about anastomotic stricture, which is the commonest out of the strictures, you typically see these very focal narrowing, which could be pretty tight. And again, it's usually single, very short in length. And the main job of the endoscopies here is to try to dilate that stricture. Now, putting a balloon dilator like in the middle diagram and just blowing it up can do the trick during the procedure very nicely. And here you can see almost 100% improvement with very minimal wasting of the balloon right at the stricture level. So you can feel very well that you're doing something good. But if you actually pull out that balloon and leave the patient as is, the recurrence rate is going to be tremendously high. So a technique of putting multiple plastic stents side by side in order to create sort of an ongoing dilation of the stricture was developed and really promoted by an Italian group, by Guido Costamagna. And you can see here several plastic stents put all side by side, and that's going to keep the bile duct open and sort of offer continuous dilation of the stricture. Now, there's another important advantage of putting multiple plastic stents is that a plastic stent, I usually try to explain to patients, is this very tiny 2 to 3 millimeter tube in diameter, and any sort of degree of sludge can easily start clogging it. The advantage of having multiple stents is that the bile is going to flow through the stent, but also in between stents. So you have sort of several channels now open for bile flow, and the obstruction rate is actually diminished dramatically compared to a single or two stents. So the more stents you put, the higher the patency over time. Now, again, the use of multiple stents has the advantage of creating this sort of dilation effect. And the more stents you put during the ERCP, the less procedures are going to be required overall, and the higher the resolution rate of the stricture. So that's why you're going to see for tight strictures, we usually keep going 2, 3, 4 ERCPs and trying to progressively put more and more stents, usually a combination of 7 French and 10 French, with 7 French being just over 2 millimeters, the 10 French just over 3 millimeters in diameter. Now, these are the plastic stents that we use on your left-hand side, and on the right-hand side, it's a metallic stent. The diameters I just gave you are for those blue little stents. The metal stents actually come in a much bigger diameter, which is about 8 millimeters or 10 millimeters for the major U.S. manufacturers. And so some people have decided, why don't we use the bigger stent up front and avoid having to put multiple plastic stents, which could be a hassle during the procedure. And obviously, once you put the first one, the second one becomes a little bit more difficult, the third one becomes more difficult, and after a while, you're really pushing the other stents side by side more than anything. So the metal stents offer a nice therapeutic strategy, at least in concept. So this was recently studied by a Brazilian group, and they compared the self-expandable metal stents, which are SEMS, and multiple plastic stents, and they were able to actually give us very nice data that up to this date has been pretty mixed. So I think this data is actually quite helpful for clinical practice, because the success rate, as you see here, both in the intention to treat and the per protocol, was quite lower compared to the multiple plastic stents. And also the stricture recurrence rate was actually about a third compared to 0% in the multiple plastic stents. So this data suggests that if you have an aggressive approach with plastic stents, you're probably going to do better than trying to open up the stricture all at once with one stent and sort of a less number of ERCPs. So it really favors repeated ERCP with multiple plastic stents, and usually the average number of ERCPs for multiple plastic stents in the literature has been somewhere in the 3 to 4 procedures. This is an anastomotic stricture that a fully covered metal stent was placed, and here's where the anastomotic stricture is. So you can see that the procedure itself is going to be much quicker and easier actually for the endoscopies. The delivery system of this type of stent is relatively smaller than some of the plastic stents, particularly the 10 French or the 11.5 French. So you can actually get this through easily through an anastomotic stricture that's relatively tight. It actually allows you to put a little bit more force through the catheter, so it's also convenient in that sense. But as you saw, the data seem to suggest that multiple plastic stents are better compared to this sort of single approach. Here's the resolution of the stricture with obviously some discrepancy in diameters of duct, but flow was restored and normalization of liver chemistries. And this is how the stent looks inside. So sometimes this type of strictures, particularly the anastomotic stricture, can be very tight, and about 9% of the time the endoscopy is going to fail traverse the stricture. There are a couple of additional techniques that can be used. PTC is a very useful technique for any type of biliary intervention, and liver transplant recipients are obviously not an exception. PTC entails a puncture of a bile duct from outside by an interventional radiologist and passage of a guide wire and instruments down into the duodenum. So what they can do for us usually is put a guide wire or an intra and extrahepatic drainage that is heading now into the duodenum, and we can use sort of as a way to get back into the bile duct proximally, that what is called a rendezvous procedure. EUS has gained a lot of grounds in this area, particularly because now biliary access can be achieved with this technique. So instead of puncturing the liver from outside, you can actually puncture easily the left lobe with EUS and drive a guide wire from the stomach into the left lobe and down into the duodenum, and you can actually switch scopes and meet the guide wire in the second portion of the duodenum to work your way up now in a retrograde fashion. Colangoscopy has dramatically improved with the new equipment that came into the market just a couple of years ago, because what we had before was fiber optic, and it was really a bad image. I had some experience with that one, and it was horrible. You couldn't really see what you were doing. You had to have a lot of imagination. The new equipment actually gives you real-time pictures that are similar to the ones you tend to see on books. So now you really know what you're doing inside the bile ducts, and the image is quite good. So there was actually a recent paper that did a cost-effectiveness analysis and particularly in liver transplant recipients, this was a relatively small case series, but still worth mentioning, that compared the cost of PTC, EUS guided intervention, or colangoscopy. And colangoscopy seems to be sort of the most cost-effective, even though it adds somewhere in the $3,000 range, $3,000 for the procedure itself. Obviously, PTC is going to be significantly more expensive. So in addition to cost, it also appears to be the safest option because the endoscopy is already in there. The current equipment, and basically you just ask the tech to bring you the cholangoscope and attach it to the scope and go through it right away. So you don't have to really book the patient for a different procedure or anything. We have it readily available in our unit, and it's a great piece of equipment. This is how it looks from inside. These are not our pictures, but again, if there's significant issues traversing the stricture with the guide wire, you can put this camera inside the bile duct and start looking exactly at how the stricture looks inside. And this is with the digital cholangoscope that is currently available. You can see the images are quite good, and just out of experience, the images that you freeze and take are usually way worse than the ones you see in real time on the monitor. So the live image is actually very, very good. And you can see here that the stricture is identified, and the guide wire, you can pass it and just see how the guide wire goes through. So for non-anastomotic stricture, which are completely different type of stricture, now we have a sort of separate etiologies. Ischemia, pre and post-transplant, is one of the major drivers for this issue. Recurrent PSC can happen, as you're well aware, and this will lead to stricturing of the duct similar than the primary sclerosing cholangitis in the non-transplant setting. And there's also a thought that diagnosis of autoimmune hepatitis could lead to non-ischemic strictures, and that is not well understood why autoimmune hepatitis, purely autoimmune, will lead to this type of events. The location, they tend to be proximal to the anastomosis, and they can be in the intra or extrahepatic bile ducts, but again, these tend to be more diffuse type of strictures and usually multiple in number. Non-anastomotic strictures have an interesting role on patient and graft survival. So as you can see here, the patient survival rate diminishes slightly for non-anastomotic stricture, but it didn't give statistical significance, at least in this series that was published almost 10 years ago. Well, now, graft survival is adversely affected, and this is important. So people with non-anastomotic strictures will develop sort of graft failure more rapidly than controls, and this may require consideration for retransplantation several years down the road. How do we manage endoscopically this type of strictures? You can argue that a similar strategy can be employed using stents, but the outcome is much worse. So you can stent as many times as you want this type of stricture. You can dilate, but you're getting inside the bile ducts in the liver, so you cannot put 3, 4, 5 stents in those smaller type of bile ducts. So usually 1 or 2 stents are going to be the rule, and they tend not to respond as well as the anastomotic strictures. About 50% of patients may ultimately require retransplantation, and this just tells you that the failure of endoscopic therapy is quite high. So this is an image of a sort of diffuse ischemic type of anastomotic stricture, proximal and intrahepatic. What you can do is obviously put your smaller dilators there and start trying to create some space for stents mainly. Because if we don't dilate, it's very hard to put these stents inside the liver through these fibrotic areas. And you have to, I always tell the fellows particularly, we're working about 1 meter out from the duodenum, so putting pressure from this far, usually it's really hard to traverse a tight stricture. So dilation really helps us to create space for the stent to go in, and we can do that in as many segments as needed. This particular case, the right lobe was drained in the anterior and posterior segments, and the left lobe was also drained. And you typically leave these stents for 2 to 3 months and then plan to exchange them, reevaluate, but tends to be sort of a more chronic venture for the endoscopist because this sort of persists. Colangoscopy that we talk a little bit about for anastomotic stricture can be helpful for the non-anastomotic type of strictures, but more for sort of a diagnostic type of yield more than therapeutic. With colangoscopy is a big catheter, so once you start getting into the intrahepatics, you start losing a lot of mobility. So it's a great technique for the extrahepatic bile ducts, for the common bile duct, for the hepatic duct. Once you start getting to the right and left, you start sort of getting a little bit clumsy, and then after that, it gets quite tricky. It depends a lot if there is or there is not biliary dilatation for you to be able to continue to advance. But it can be a sort of a useful technique in particular cases that you're having some doubts, particularly about the diagnosis, or you want to have sort of a guide wire placed in a very specific location. Now, moving into bile leaks, this can happen in up to a quarter of patients. Risk factors for early and late recurrent, early and late strictures. Obviously, a bile leak is going to create a lot of inflammation, and that inflammation may translate into fibrosis. These are also stratified by timing. 1 month or less are considered early. More than 1 month are considered late. And when we're talking about early bile leaks, they're usually related to the anastomotic site, so the colostomy, and technical issues may have an important role there. Now, inadequate blood supply to the bile duct is also going to be an issue related to this problem, and they tend not to be related to the type of biliary anastomosis as someone will think, but the anastomosis doesn't have anything to do. Now, the late ones, removal of a T-tube, which was previously used more often, had a major role, and the late type of bile leak have a high risk for biliary strictures. You can sort of group them by the anatomic location, and they can be actually right at anastomosis level. Again, a T-tube ischemic injury type of problem will have a major impact on this particular location. It can be related to a cystic duct stump, as any post-cholecystectomy bile duct, or can be related to the cut surface of the liver, particularly in living donor liver transplant. This is what we usually do in endoscopy, and just 2 examples, one of a sort of a more mundane type of bile leak, and the other one related to a T-tube tract. The treatment is about the same, and we can deal with this issue quite effectively with endoscopy. The main goal here is to restore bile flow from the bile duct into a duodenum. So what we do is to decrease what's called the transpapillary gradient of the pressure by cutting the sphincter of Vodi and usually putting a stent to bridge. For non-transplant populations, either technique has been suggested to be effective for sort of low volume bile leaks. For high volume bile leaks, it's advocated that you should use a combination of the two, sphincterotomy and stent. For transplant patients, usually they get sort of the double technique, sphincterotomy and a stent placement. When we have a biloma, this is usually associated to a bile leak somewhere in or out of the liver, and this can also be associated to ischemic events of the bile ducts. And the management, it's actually depending on where, if there is or not a communication with the biliary tree that can be identified. So if there is a communication, again, reducing the transpapillary gradient plays a major role, because then you're going to restore flow into the duodenum, and bile is preferentially going to be draining down there instead of coming out or extravasating. If there is not communication with the bile duct, then there's an issue, because you can deal with the stent or sphincterotomy as many times, but this is not going to help significantly. Percutaneous drain or surgery is going to be sort of the way to go. When we talk about other issues like stone, sludge, or cast that are quite prevalent, particularly in our population here in Texas and the non-transplant population, you actually see these issues commonly in transplant recipients when you have narrowings or strictures or sort of ductal mismatches that will favor sort of cholestasis and stone sludge formation. So stricture is a major risk factor for this because it will retain bile. It will make precipitation much more precipitation environment much more favorable. Ischemia times, warm and cold ischemia times, are going to be somehow related to ischemia as well, and sort of the ischemic type of strictures that are primarily related to casts. Bacterial infections and biliary obstruction, those are obviously risk factors in the non-transplant population. They also play a major role in the transplant population. Stones and sludge typically occur late. So as you saw initially in one of the plots, the strictures tend to occur early, and then you're dealing with sequela. So if there is sort of a remaining stricture there, you're probably going to be at high risk of late sludge, stones, or casts. So the median time has been about 19 months after transplant, and they tend to have a relatively high recurrence rate. So this could also be associated to genetic profiles of cholesterol supersaturation of the bile. Some ethnic groups are predisposed to stones much more than others. Casts are this sort of big type of stone or mudgy looking like bile right here that are going to form usually with ischemic strictures. They're sort of long feeling defects in the bile ducts, and they can create significant issues because they're hard to remove with endoscopy in one try. Usually you can remove as much as you think it's possible, but most of this cast will require subsequent ERCPs to achieve complete ductal clearance. Sphincter of Vodi dysfunction is an interesting disease or phenomenon in the non-transplant and transplant population. In the non-transplant population, I think there are less and less people interested in doing manometry of the sphincter of Vodi nowadays. I know Sandeep Patel has some interest in the sphincter of Vodi, and he even has a clinic on it. So he's probably one of the few that are out there right now. And in the transplant ward, it's thought to occur in about 2 to 7% of the time, the dysfunction of the sphincter. And what's being proposed is that there is a denervation of the sphincter of Vodi happening during the surgery, and that will create probably an issue with this phenomenon. Now, in the non-transplant population, it typically manifests with three findings: colicky, biliary type abdominal pain, elevation of the liver enzymes, and a dilation of the bile duct. And there's 3 types according to if you have 3 out of those 3, 2 out of 3, or just pain. And it goes from the sort of the most responsive one to endoscopy to the least responsive to endoscopy, which tends to be just pain without elevation of the enzymes or dilation. In the transplant ward, it's difficult to make a diagnosis if you have sphincter vodi manometry available. That's something that could be considered in order to diagnose it. The reality in the non-transplant and transplant populations is when there is any doubt, we usually go in and cut the sphincter and done. So when in doubt, we usually go straight to the therapeutic maneuver and just decrease the pressure of the sphincter, and that way you obviate the need for a manometry of the sphincter vodi, which can be quite challenging. Now, the abdominal pain that we talk a little bit in the non-transplant population is typically absent in the transplant ward. So this is going to be mainly an issue of sort of a smooth, long dilation of the bile duct that's not involving the anastomosis, and it's giving elevation of the liver chemistries, and probably rejection has already been ruled out through histology. So that's when sort of a spastic or a non-relaxing sphincter can be suspected on clinical grounds. And again, if manometry is not available, just going after a therapeutic intervention will be sort of what most people do. ERCP has complications. It's an invasive procedure. We tend to think it's quite benign, but it actually has complications in both non-transplant and transplant populations. When we quote numbers for non-transplant populations, we usually quote somewhere in the 10% range for complications, and that's exactly what was noted actually in transplant patients, 9%. We usually tell people that the commonest adverse event is going to be probably pancreatitis, and that happens somewhere in the 5 to 7%. Now, in transplant populations, it's been reported slightly lower, with the caveat that this was just 121 patients. So if we actually study a larger number, we'd probably come up relatively comparable. But what's interesting is that we're not seeing higher than in the non-transplant populations. So the side effect profile is about the same. We have to be mindful about pancreatitis, we have to be mindful about cholangitis, and we have to be mindful about perforations and bleeding. A couple of interesting things. This is a retrospective study, but was able to come up with risk factors for complications in the transplant populations. mTOR inhibitors were associated with an odds ratio of 4.6 for complications. High creatinine was also associated with significant risk for complications, so sort of implying that the sicker the patient in a multi-organ fashion is, the higher the risk for this type of intervention. We know very well that every time we cut during an ERCP, we increase the risk. Now, in the transplant ward, we cannot usually get away without cutting, because if you're going to be dealing with a biliary stricture or a bile leak, you're going to be putting a stent, and most of the times we have to make room for that stent by cutting. In non-transplant patients, you could argue that the bile leak can be dealt just by stent without a sphincterotomy, which will minimize the risk of bleeding and the risk for pancreatitis, at least in theory. What was interesting in this series from liver transplant recipients was that prednisone was associated with a reduction of post-ERCP pancreatitis in particularly. And this has been widely studied in non-transplant patients, and we haven't had any luck so far. Prednisone does not decrease pancreatitis post-ERCP, but what has been found to improve pancreatitis is another anti-inflammatory agent, which is indomethacin or diclofenac, which we give relatively often to non-transplant populations. This graph from the same paper is interesting because it actually demonstrates that the more ERCPs you do in the same patient, the lower the risk of complications. And this we've seen also in non-transplant populations. Sort of the initial procedure carries probably a high risk, particularly for pancreatitis. The subsequent procedures, usually the risk is less and less, because one, you probably have made a nice opening there and it's easy access to the bile duct. Two, you're sort of more familiar with that patient, particularly if the same endoscopy is doing the case repeatedly. So it doesn't mean that the risk becomes negligible, but I think you become a little bit more and more used to doing the same patient, or the stricture starts to respond, so you have to be less and less aggressive with balloon dilations that during the initial one, and the stents are actually quite safe, so they don't pose significant risk on exchanges. So in conclusions, biliary complications are very common, and again, you see this on a day-to-day usually. Biliary strictures tend to be one of the most concerning problems, but nowadays endoscopy can deal with this issue quite easily. Patient and graft survival can be compromised, as you saw. Anastomotic strictures can have an impact on both. Non-anastomotic strictures at least appear to decrease graft survival, and it's something that needs to be dealt on an early fashion. The earlier the diagnosis and treatment, the quicker the response for endoscopic therapy at least. So it's something that we need to identify rapidly and get on to management. Endoscopic therapy should be sort of the way to go, at least in this day and age. PTC and others are sort of salvage techniques for failure of endoscopic therapy. PTC still has an important role for Roux-en-Y biliary anastomosis, particularly if the endoscopist doesn't have the balloon-assisted enteroscope device available, which is the case for most places, except academic centers that are really have adopted this technique nowadays. Repeat procedures are sort of the norm in this type of population, so it's not a slam dunk that we're going in and taking care of the stricture in one session. Patients are usually requiring 3 to 4 on average for anastomotic strictures. Bile leaks, usually you require between 1 and 2 interventions, and ischemic type of strictures are probably going to be an ongoing need for endoscopic therapy. So with that, I'd like to thank you again for having me here, and I'll be glad to take any questions.